Good evening, delegates and all the participants. Thank you for joining Shield Connect. Today, the icon of the day is Ma'am herself. Ma'am is going to speak on topic UTI in pregnancy. Let me introduce Dr. Ritu Santwani, ma'am. Ma'am has done MBBS, MD, FICOG, FIAOG, AMR COG. Ma'am is an obstetrician and gynecologist IVF. Ma'am is the founder and CEO of 360 Degrees Healthcare Studio. Ma'am is also a consultant at Inamdar Multi-Speciality Hospital, Pune. Ma'am is infertility test tube baby specialist. Ma'am is also a part of NUHS Singapore. Ma'am is the founder of MAAM, board member of SWWC. Now I would like to hand over the session to Dr. Ritu Santwani, ma'am.
Yeah. Thank you, dear Sahiti, and thank you, Shield Connect, for providing the platform. So a very, very warm welcome to all of my dear friends who have joined all across the geography. Yeah, a big hello to Dr. Bashir Hussain. Thank you, dear friend. Dr. Bashir has joined all the way from Somalia. He is the secretary of the Somalia Society. Too good to see dear friend Dr. Tanvi. Hi, Tanvi. Dr. Renu Bhatia Madam, Dr. Uruz, Dr. Rita Jha. So many friends have joined. Yeah, very warm welcome. So friends, today, yeah, hi, Dr. Rashmi. Too good to see you. So, yeah, hi, Dr. Megha. Yeah, hi, Rashmi. So, today we are going to discuss a very important topic, the urinary tract infection in pregnancy. So, we all see every day the patients are coming for this urinary tract infection in the pregnancy. There are so many confusions in our mind. So I tried to clarify some what we are getting in our day-to-day practice. Friends, sorry, a little bit disturbance because still I am at my center only, not reached home yet. So little bit of voice disturbance is there today. Just started sharing of my screen. Yeah. I hope slides are visible.
Yes, ma'am.
Yeah. Okay. Okay. Yeah. Thank you, dear Sahiti, for introducing me.
Welcome, ma'am.
Yeah. So friends, as all are aware, my all presentations always started with Mata Durga Rani Stuti. Ya Devi Sarvabhuteshu Chikitsa Rupen Sansita Namastasyai 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 Namo Namah. So the topic, as I told, we are going to discuss today UTI in pregnancy. So friends, as always, the topic should be very interactive. In between also, if any of you are having any queries, you can write in the chat box and later on we can discuss everything. Yeah. So as we all aware that UTI during pregnancy is independently associated with preterm delivery, IUGR, preeclampsia and cesarean deliveries. So according to definition, the asymptomatic bacteriuria, when more than 100,000 organisms per ml of urine, symptomatic when 100 organisms per ml of urine with accompanying pyuria, means more than 7 WBCs per ml. Diagnosis should be supported by a positive culture, particularly with vague symptoms. Risks associated with this are pyelonephritis, preterm birth, low birth weight, and increased perinatal mortality. As we all know, the incidence of asymptomatic bacteriuria, when we are finding more than 100,000 organisms per ml in 2 consecutive urine samples in the absence of symptoms. The incidence has been reported in the pregnant patients is 2.5 to 11%, and the non-pregnant patient is 3 to 8%. So, yeah. Now, how to classify this? Yes, the first and foremost important is the acute cystitis, is the inflammation of the bladder, bacterial or non-bacterial causes. Example is radiation or viral infection in 1% of the pregnant patients. So friends, here we can see in the acute cystitis, the presentation may be either is the dysuria or the frequency, urgency, foul smelling urine, in some cases the hematuria and the suprapubic pain too. Mostly the patients come with the complaint of the dysuria and increased frequency. Other presentation is maybe by the acute pyelonephritis, in which the 2% of all pregnancies, 2% during the first trimester, 52% during the second trimester, and 46% in the third trimester. So, as we all know, the epidemiology, the UTI in women is 14 times more frequent than men. What are the reasons? As we all are aware, as in the females, the urethra is shorter, and lower 1/3 of the urethra is continuously contaminated with pathogens from the vagina and the rectum. Women tend not to empty their bladder as they completely as the men do. Urogenital system is exposed to bacteria during the intercourse. So increased frequency of UTI in the pregnant female either may be due to difficult hygiene due to distended pregnant belly, or may be due to immunocompromised conditions. Or may be due to hormonal and mechanical changes, as we all are aware. As in the pregnancy, the urinary stasis and vesicoureteral reflux. Urinary stasis is due to progesterone-induced ureteral smooth muscle relaxation. Urinary retention is maybe due to the weight of the enlarging uterus. Loss of the ureteral tone combined with the increased urinary tract volume, urinary stasis, dilatation of the ureters, renal pelvis, and calyces. More commonly seen on the right side, especially it is reported up to in the 86% cases on the right side. More pronounced on right, 15 mm versus 5 mm, begin at 10 weeks and worsens throughout the pregnancy. Other presentation may be like the glycosylluria and amino aciduria. Glycosylluria, impaired resorption by the collecting tubule and the loop of Henle of the 5% of the filtered glucose, which escapes the proximal convoluted tubular resorption. Selective amino aciduria, although its presence has been postulated to affect the adherence of the E. coli to the urothelium. Now, friends, as we all are aware, for this asymptomatic bacteriuria, the risk factors are 5-fold poor patients, doubled in the cases of the sickle cell trait, and other risk factors are reported as diabetes mellitus, neurogenic bladder retention, history of vesicoureteral reflux, previous renal transplantation, history of previous UTI, multiple pregnancy, and the prolonged hospitalization. Sahiti, is my voice is coming clear or you're getting disturbance? Can anyone tell me voice is coming clear?
Yes, it's clear. Yes, clear.
Okay. Thank you, Dr. Vashi. Thank you. So now coming to the pathophysiology, the infections results from ascending colonization of the urinary tract, primarily by existing the vaginal, perineal, and fecal flora. So here we can see in this diagram, in the vaginal introitus, by the fecal E. coli sticks the epithelial cells. Similarly, by intercourse or by the usage of the diaphragm or spermicide with the bladder, the stasis and obstruction increases the chances of the infection. So this is a very simple diagram which shows the toxins are filtered out as urine from the kidney and carried away via the ureter, and they are temporarily stored in the bladder, and then it has to come out, the final outlet by the urethra. So now what causes this UTI? Why in the female, being in a woman, yes, as we have just discussed, the anatomical disadvantage. Then most by the sexual intercourse may introduce the harmful bacteria from the genital intercourse, which may allow the bacteria to grow. Then via this catheters allow the bacteria to flourish, while in the pregnancy the altered immunity and defective flushing. Similarly, the suppressed immune system and diabetes. Similarly, in the menopausal ladies, so we are discussing today only regarding in the pregnant ladies, altered pH and defect in the immune system. So now what the incidence suggests, the UTI is the second most common infection following respiratory infections. 40% of all women will suffer at least one UTI at some point. 1 in 5 of the women between the ages 20 to 65 suffers one attack per year. Approximately 30% of the pregnant women suffer from UTI. So now what are the natural defense mechanism in our body for the UTI? Urine becomes acidic during UTI, which kills the most bacteria. A drug is available, the D-mannose in urinary tract does not allow the bacteria, the D-mannose in the urinary tract does not allow the bacteria to stick to uroepithelial wall. Bacteria moving upwards and regularly flushed out by the urination. So the symptoms of this may be either pain, fever, low backache, burning micturition, frequent urge to urinate, or the fatigue. What adds to the trouble is the frequent recurrence of UTI. So in this, a triad of the burning micturition, pain, and the recurrence. Here, as we just discussed, the urine becomes more acidic. Infection in the urinary tract leads to inflammation. The flow of the urine irritates the urinary tract. Infection triggers the release of many chemicals, which causes the inflammation of the urinary tract, resulting in pain. Then when we say this recurrent UTI, if the UTI occurs minimum 2 times in 6 months or 3 times in a year, we use the term as a recurrence 2 times in 6 months or more than 3 times in a year. Recurrence happens because E. coli tends to hide within the cells of the urinary tract. It is difficult to flush out or kill such hidden E. coli. So, as we all know, the E. coli is the most common cause of the UTI. In 80 to 90% of the cases, originates from the fecal flora, colonizing the periureteral area, ascending infection, while other pathogens like Klebsiella pneumoniae 5%, Proteus mirabilis 5%, Enterobacter species 3%, Staphylococcus saprophyticus and other are reported the group B beta hemolytic streptococcus and proteus species. Among this, the S. saprophyticus is an aggressive organism for upper urinary tract infection, persistent or recurrent, urea splitting bacteria, Proteus, Klebsiella, Pseudomonas, coagulase negative, Staphylococcus, alkaline the urine. Plus the chlamydal infections has been reported, the sterile pyuria and 30% of the atypical pathogens. Again, in the patients of the preeclampsia, the studies have shown it is predisposed to UTI, 16.2% in normotensive, while 27.3% in mild PAT, while in 35.9% in severe PET patients. Underlying renal damage weakens the patients and systemic defense mechanisms against ascending infection. So now what are the complications has been associated? The UTI during pregnancy is independently the IUGR, preeclampsia, preterm delivery, and cesarean section. While in cases of the asymptomatic bacteriuria, most commonly we see the patients of the asymptomatic bacteriuria in our OPD. Once we tell the patient for the routine testing, sometimes we find they are suffering from the asymptomatic bacteriuria, acute cystitis, pyelonephritis. Acute cystitis approximately 40%, while pyelonephritis 30%. Risk of preterm birth 1.8 to 2.3%. Acute cystitis, low birth weight and preterm delivery. Pyelonephritis in the cases 15 to 50% of the cases. The other complications what has been reported, the perinephric cellulitis and abscess, septic shock rarely, the renal dysfunction usually transient, but as many as 25% of the pregnant women with pyelonephritis have a decreased glomerular filtration rate. Hematologic dysfunction, common but seldom of clinical importance. Pulmonary injury, 2% of the women with severe pyelonephritis. As we all know that for the diagnosis, the cystitis, dysuria, the most significant symptom. Other symptoms like frequency, urgency, suprapubic pain, hematuria in the absence of the systemic symptoms. The usual complaints of increased frequency, nocturia, and suprapubic pressure are not particularly helpful. While in the cases of the pyelonephritis, the fever more than 38 degrees centigrade, shaking, chills, anorexia, nausea, and vomiting. Right-sided flank pain is more common than the left side or bilateral flank pain. Lower UTI symptoms are common but not universal. And hypothermia. In the pyelonephritis, usually the fever, flank tenderness on the right side in more than half of the patients, bilaterally in 1/4, or on the left side in 1/4. In these patients, the assessment of fetal heart rate is very important in the cases of the maternal fever. So investigations, as we all are aware, the CBC, serum electrolytes, blood urea nitrogen, and serum creatinine. Among this urine, in the all pregnant females, the urine analysis and culture in the first prenatal visit or at 12 to 16 weeks to identify the asymptomatic bacteriuria as well as those with the other concerning findings such as glucosuria, midstream clean catch sample to be taken. We have to give the instructions to the patient with one hand to spread the labia, while with the other hand use a castor soap or moistened toilet to wipe the ureteral meatus downwards towards the rectum, and then discard that. void the initial portion of the bladder contents into the toilet and catch the middle portion of the bladder content into the sterile container while keeping the labia spread with the first hand. Then amongst this urine culture, evaluating the UTI for, as we all know, in the recurrent UTI, pyelonephritis, failure to respond to the initial treatment, history of recurrent instrumentation and the hospital admission. Then what if the culture comes positive? The two consecutive voided specimens with the isolation of the same bacterial strain at a colony count of 100,000 colony forming units per ml or high OR, a single catheterized specimen yielding a colony count of at least 100 CFU per ml may be the contamination if the counts lower than 100,000 CFU per ml or with two or more organisms. Patients with pyelonephritis often have the WBC cast. Culture results can be used to identify the specific organism and antibiotic sensitivities. Cultures yielding the significant growth of the mixed organism should prompt a search for underlying the renal calculi. So now what are the guidelines for this UTI treatment in the pregnancy? We will discuss for the asymptomatic bacteriuria, for acute cystitis and acute pyelonephritis. So for asymptomatic bacteriuria in pregnancy, as we know, the diagnosis when the presence of the 100,000 CFU per ml in one or more uropathogens in two consecutive midstream urine specimens or one catheterized urine specimen in the absence of symptoms attributable to a urinary tract infection. Then screening, when all the pregnant females must be screened for ASB in the first prenatal visit between the 9th to 17th weeks, preferably on the 16th week age of the gestation. Then coming to the optimal screening test, as we have just discussed regarding the midstream urine. Among this, the studies have shown, the studies have been presented by Archibald and McLeay and Robertson. The areas where the urine culture is not available, but this, I think it's available in every place now. So better we will skip this. Yeah. So now what is the effective treatment in the pregnancy? The antibiotic treatment for asymptomatic bacteria is indicated to reduce the risk of acute cystitis and pyelonephritis in pregnancy, as well as to reduce the risk of the low birth weight neonates and the preterm infants. It is recommended that antibiotic treatment should be initiated upon the diagnosis of ASB in pregnancy. Amongst the drugs that can be used as nitrofurantoin, not for those who are near term, amoxiclavulinic acid, cephalexin, and also these days we are not using the 4-trimoxazole, but it is reported, so that, but not in the first and third trimester, depending on the sensitivity results from the urine isolate. A 7-day course has been recommended. So here, friends, we can see the nitrofurantoin, amoxicillin clavulinate, cephalosporins, and this trimethoprim and sulfamethoxazole has to be avoided in the first and third trimester. Better not to give, huh? And yeah. So this is the different risk categories for the different drugs. Then coming to acute cystitis in the pregnancy, which is characterized by urinary frequency, urgency, dysuria, and bacteriuria without fever and costovertebral angle tenderness. Gross hematuria may also be present. In the pregnant female suspected to have acute uncomplicated cystitis, Obtain a urinary culture and sensitivity test and a midstream clean catch urine sample. Then, if the pre-treatment diagnostic test is required in the acute cystitis in pregnancy. So, friends, what the studies suggest, in the absence of a urine culture, the laboratory diagnosis of acute cystitis can be determined by the significant pyuria, means more than 8 parcels per mm³ of uncentrifuged urine, or more than 5 parcels in high power field of centrifuged urine, or a positive leukocyte esterase and nitrite test. Then coming to the acute pyelonephritis in pregnancy, that what antimicrobials are recommended. So for the pregnant patients with no signs and symptoms of sepsis and are able to take medications by mouth, considering the outpatient therapy. So any of the antibiotics can be used except fluoroquinolones and aminoglycosides, which are relatively contraindicated in the pregnancy. Then, what is the clinical utility of a post-treatment urine culture in acute pyelonephritis? Post-treatment urine culture should be obtained to confirm the resolution of infection. Patient should be monitored at intervals until the delivery to confirm the continued urine sterility during pregnancy. Then, the dipstick testing for nitrites and leukocyte esterase in the evaluation of an asymptomatic bacteriuria, sensitivity 50% to 92% and specificity 86% to 97%. In the evaluation of symptomatic, useful and inexpensive, leukocyte esterase test may be unreliable in the patients with low level pyuria. The addition of protein and blood increases the sensitivity and specificity to the test in the evaluation of UTI. Then, amongst this, urine cytology is useful as an adjunct for detecting or this. Then, the clumping of WBCs and WBC cast, pyelonephritis, RBC cast, acute glomerulonephritis, oval fat bodies and fatty cast, membranous glomerulonephritis, renal involvement, proteinuria, nephrotic syndrome, high proteinuria, more than 3.5 gram per 24 hours, edema, hypercholesterolemia, hypoalbuminemia can be confused with preeclampsia. Renal ultrasonography and IVP in the cases. An anatomic abnormality or renal disease is suspected. Patients with suspected pyelonephritis who are not responsive to appropriate antibiotic therapy after 48 to 72 hours. Recurrent UTI or symptoms that suggest nephrolithiasis. For this, it suggested the total dosage of ionizing radiation should not exceed 3.5 CGY during the course of the pregnancy. Of particular concern of the radiation delivered during the first trimester during the time period of the organogenesis. Then radiation doses of more than 5 CGY increase the likelihood of benign and malignant tumor in the child after the birth. No patient should receive more than 10 to 14 CGY. Then what's the treatment has advised? And the treatment is advised the initially conservative, 50 to 67% diagnosed during the pregnancy. Then the antibiotic, hydration, analgesics, usually the narcotics, which are the class C agents in pregnancy, anti-inflammatory, oligohydramnios, premature closure of the PDA or both should be avoided if possible. So now what are the treatment is advised? Bacteriuria and cystitis, administration of appropriate antibiotics, administration of fluid if the patient is dehydrated, and admission if indicated for the complicated UTI. So now what is the, which antibiotics? So oral antibiotics are the treatment of choice for asymptomatic bacteriuria and cystitis. So as we know, the single dose treatment, amoxicillin 3 gram, ampicillin 2 gram, cephalosporin 3 gram, nitrofurantoin 200 mg, and trimethoprim sulfamethoxazole 320 and 1600 mg. And phosphomycin OD has been reported in the literature. But these days, if you ask me, my drug of choice is the phosphomycin. Yes, of course, some patients may suffer from the diarrhea after giving the phosphomycin, but we have to give the proper instructions because it is a single dose. We are getting a very good results by the use of this drug. Of course, it is costly. Then 10 to 14 days of the treatment is recommended to eradicate the bacteria. Treatment for 3 days recommended for asymptomatic bacteriuria. Regular urine culture should be taken. Antibiotics should be continued for 5 to 7 days in the cystitis. Yeah. So, the use of the existing fixed dose combinations, as we all know, alkalizer and cranberry D-mannose. So there are different available. In some patients, we are giving the flavoxylate, but with the flavoxylate, which are containing the flavoxate, does not contain the alkalizer and cranberry D-mannose. So we have to give the combination which can cover all the things. So the drug which can usually there are a lot of drugs are available in these days. The one which is having a combination of ursolic acid and the potassium magnesium citrate and the cranberry extract. So which will cover all the three. So by giving this potassium magnesium citrate, it normalizes the pH of the acidified urine in the infected urinary tract. While with this ursolic acid, the powerful anti-inflammatory and analgesic effect. While this cranberry, as we all know, these days we are getting a lot of Google savvy patients. Before coming to the doctor for the treatment of the UTI, they tell, ma'am, we have read somewhere the cranberry juice is good. So we have already taken this cranberry juice. Yes, of course, it gives a very good results too. Then again, the lot of studies has been presented for this, the use of this cranberry juice for the treatment of the UTI. The studies have shown that it inhibits the natural killer TSKB transcriptional response in human T lymphocytes. LPS stimulates the release of interleukin 1 beta 6 and TNF and catalytic activity of COX-2. So, a lot of studies have shown that cranberry may reduce the symptoms of UTI through its anti-inflammatory effects. It inhibits the cytokine release in the human peripheral blood mononuclear leukocytes. See, friends, this two slide, when I preparing the presentation, I got a very new study. This study has come very recently, and you can see in 3rd November 2022. I have just added these slides in the afternoon only. So the new antibiotic appears to be effective against the urinary tract infection. The drug, a new drug has been come. So still lot of trial has been going on. The new antibiotic called gipotidacin, which works at least as well as the nitrofurantoin. A current frontline medication is used to treat the UTI. So this is something new what I found when I'm searching in the literature. Gipotidacin. So then coming to the surgical treatment, they rarely indicated unless one of the pathologic causes listed in the differential diagnosis is suspected. In the patients with ureteral or bladder diverticulum, bladder stones, ureteral syndrome, and lower urinary tract trauma, interstitial cystitis, or bladder cancer, cystoscopy may aid in establishing the diagnosis. A retrograde stent or a percutaneous nephrostomy should be placed to relieve the ureteral colic or decompress an obstructed infected collecting system. More invasive procedures such as ureteroscopic stone extraction and rarely indicated. So thank you, friends, because the topic is so vast. So thank you for your attention and time. I try to summarize in the nutshell. I just stop sharing. Yeah, so we can discuss it. Yeah. So try to summarize because the topic is so vast and we all are getting in our daily OPD these kind of patients. Yeah. Too good to see. Yeah. Hi, Dr. Anurita. Yeah. Yeah. If any questions, we can discuss. Yeah. Hi, Dr. Rosie. Hi, Dr. Ritu. How are you? Thank you. Thank you, Renu madam. Thank you so much, Renu madam, for joining.
Ritu, my question is, why
Yes, yes.
cesarean section is more common in UTI?
Ma'am, we
mentioned,
can. Yes.
But why
Yes,
it is common? Because it is just pain or something else also.
Ma'am, pain may be due to at the time of the catheterization. Some nosocomial infection, I can say, also can be in the etiology, because whatever the we are using the precaution, but still the some more safety precautions we have to be used.
Just to prevent that.
Yeah.
Otherwise, there is no other factor that is it.
No. Ma'am, while making this PPT, I have gone through the studies also, so that all are also showing like that also, because the chances of the nosocomial infections are high. That's why in some cases, in the cesarean patients, the incidences has been reported little higher. Yeah.
Thank you so much.
Thank you, madam.
Very excellent talk. Very excellent.
Thank you so much, ma'am. Thank you so much. Your blessing. Yeah. Hi, Shalini. Yeah, Shalini. Yeah, there are so many combinations are available. The trade name we can discuss in the group. If you want, I can put the name in the group. Yeah, just a second. So many questions are coming. Yeah, thank you, dear Shalini, for joining. Let me see. Yeah, hi, Sunita, madam. Thank you for joining. Just a second. I'm just opening. Thank you, Dr. Abha, madam, for joining. Yes, I am able to see one question. Yeah, thank you, dear Riza, for joining. Yeah.
Hello, madam. Hello,
yeah.
madam.
Yes. I am coming to the questions. One second, huh? Just a second, yeah.
I want to just ask this nitrofurantoin is also we can
yes
give in pregnancy furantoin.
Nitrofurantoin we can give, madam. We can give.
In third and this nitrofurantoin dose is 100 milligram BD?
Yes, 100 milligram BD, or these days we are getting the preparation for the sustained release also. Sustained release. So that you have to give OD only, that sustained release preparation.
Okay. And this furantoin is same as is different.
Ma'am, furantoin are you getting these days? I'm not getting. I've tried in some patients, so that's why I'm giving this nitrofurantoin only. And if my patient is, if you are getting, let me know also, ma'am. If any one of you are getting, please give your inputs. Renu madam, are you getting furantoin these days?
No, I am using nitrofurantoin only.
Yes. Yeah, Kamlesh madam, we are using nitrofurantoin only. I don't think it's not available.
Okay, thank you so much.
Most welcome, madam. Most welcome.
Okay, Ritu, I have to leave now.
Okay, madam.
I really enjoyed your talk. Okay.
Thank you so much, madam. Let me see. Yeah, hi, Dr. Megha. Thank you for joining, dear. Let me see. Yeah. Thank you, Dr. Ritu, for joining. Yeah. Now let me see. Yes, Rosie. Yeah. Okay. I see. Yeah, Sunita madam, you want to ask me something about the phosphomycin?
Yeah. Are you giving phosphomycin?
Yes, I'm giving, madam. I'm giving.
No, but
Uh,
is it only in the resistant cases or a routine
no, no.
UTI?
Ma'am, I the practice in the year where all the patients are the Google savvy, so I can't give
Yeah.
anything without the evidence. So if
Yes.
the patient is coming to me on the instance that they are having a lot of burning and all that,
Right.
in that case, I first start the broad spectrum, either the cefixime or cefuroxime. Meanwhile, we
Okay.
send the urine for the culture.
Yeah.
So if the patient is ready that without doing the investigation, they are ready to take the
No, that
medication.
I think that era is already gone. You can never give the patient antibiotics without even getting it. What I
Yeah.
normally do is I start citrol or some
Uh,
cefixime, and before starting the tablets, I ask them to give the urine and then
correct.
start the tablet on the next day. At least with citrol, they can pass maybe 12 hours or so, and in the morning, once they give the sample, then they should start the antibiotic, because otherwise the report is not going to be
Very
exactly
true.
correct.
Very true.
And
Very true.
phosphomycin I have given only in recurrence and certain resistant cases, but not in cases where the colony count is say like around 80,000 or so. There I have given cefixime or levoflox, citrol, and then maybe furidentine sometimes, nitrofurantoin. But I do not have much experience of phosphomycin. That is what, because I have given hardly in about 4 or 5 patients.
Okay.
I wanted to
Okay.
know
Okay.
how it is your
Ma'am,
experience.
I have more experience with the phosphomycin because
Yeah.
in my area, the patients are not ready to take the tablets for 3 days, 4 days. So they
Yeah.
want a single shot. So
Single
yes,
shot. Yeah.
because the phosphomycin, of course, the cost factor is there. One
Yes.
sachet is costing now from different companies 350 to
Yeah.
500.
Yes.
But
Yes.
only the one disadvantage, we have to explain the patient properly. And
Right.
because some patients will get a lot of loose motions, diarrhea is a
Yes.
major
Yes.
complaint.
Yes.
And we
Yes.
have to
Yes. Right.
explain the patient that after properly emptying the
Right.
bladder, you have to take this.
Mm,
Um,
mm.
and some
Yes.
patients we
Yes.
have to give some antidiarrheal along with that
Right.
also.
Right.
Yeah,
Right.
yeah. Thank you,
Yeah.
madam, for
Yeah.
joining.
I want to ask this, doctor, that for a proven culture, E. coli or any bacteria in pregnancy, you give only for 3 days antibiotic, or you complete the course for
No,
7 days?
complete the course, ma'am. Complete the course.
Yeah,
Complete the
because nitrofurantoin, somebody is written 100 milligram BD for 3 days. So I find it is an inadequate dose for 3 days, and it can develop a resistant bacteria.
No, minimum for 7 days, ma'am. 7 to 10 days we have to recommend.
Yes. Yes.
Yes.
7 days is minimum that we give.
It is
Yeah,
only in those cases like 3 days when you are waiting for the culture report that
yes,
you
yes,
want
yes.
to.
Ma'am,
So,
anyhow,
but
if we write for 10 days, also patient will take 3 days, 4 days. If we write for 3 days, then it's very
That's
difficult.
very right. We
Yeah.
are practicing in India.
Yes, correct,
actually,
na?
patient once get symptomatic relief, they say now thing is finished. No more medicine.
Yeah, Shalini. Yeah, Dr. Shalini. Hi. Shalini is asking, Dr. Rakia, you can get this presentation. I have uploaded. This program is going live on the YouTube channel. If you're not on my YouTube, then please subscribe the program. All the academic sessions are live on the YouTube, so you can go through that if you joined late. Huh?
Yeah,
So,
madam, your sessions are very good.
Thank you,
whenever I
madam.
get time, I keep saying, and I really congratulate you
Thank you, madam. Thank you.
being academically so much bringing us sharing the knowledge.
Yes,
And
she's
you are
polishing
ready for any discussion. That is also very great. People
You're
do
polishing
deliver
everybody's
lecture, but
knowledge.
they are not ready for any discussion. For you, it is good that you are ready for any kind of discussion. Thank you so much.
Thank you. Thank you
Thank
so
you,
much.
Ritu, for polishing everybody's knowledge.
No, ma'am. Thank you. It's my pleasure.
Thank you
Knowledge
so much.
always increases by sharing. I believe
Yes,
in that
very
funda.
true.
What
Very true.
problems I suffered when I started my practice. So that's why the purpose of these all academic programs. So we can discuss and share something I also learned, something you also learned. So that is much better, of course. Yeah.
Yes.
Only
And
one question. Yeah.
it
Yes,
was
ma'am.
very good in COVID. It was very good in COVID. I really
That's
enjoyed. Now, of course, sometimes we are able to attend and sometimes we do miss out, but that
Yes,
time we were
yes.
very
No,
regular.
now
to
so I
have
have done session only after 22nd December. I got so many requests that,
Yes.
madam, why you stopped the session? Why?
Yes.
This happens sometimes. I'm getting late in the center.
Mm,
So to go rushly. So anyhow, I
yeah.
will try to keep on continuing.
Yeah. You're practicing also, no?
Yes, I'm at my center only, ma'am. From there only I'm taking this.
So late.
So
Good. You're working for all of us.
nahi, we
Yes,
all, ma'am,
yes.
knowledge I am also gaining, not like only you.
Yes,
We all
yes.
are gaining.
Right,
Yeah.
very true.
Our
Very
dear
true.
friend Dr. Bashir Hussain is the secretary or president of the Somalia Society. From Somalia has joined. Thank you, Dr. Bashir, for joining.
Dr. Ritu Santwani, I'm very happy to attend this and conference, and we are highly appreciated because all Somalis people, they love and they also know you are very famous in Somalia.
No, thank you for your good words.
We are so happy, and we are attend a lot of time, inshallah. And thank you very much for your kind, for your teaching, for your helping, for your you want to increase the knowledge all over the world. That's why I already before we are doing a lot of meeting like this, also in Egypt and Somalia and India. Really, Dr. Ritu is very compassionate person and very nice and helping the others. Thank you very much. Thank you.
Thank you, Dr. Bashir. Too good to see my dear friends. Hi, Dr. Aparna. Aparna, kashi hai? Huh? Dr. Aparna Godbole. Huh? And yeah, hi, Dr. Abasud, madam. Good evening. लगता है दिल्ली में बहुत ठंड पड़ रही है. Good to see Tazwar. Hi, Tazwar. Yeah, I'm seeing 2 more questions. Yeah. Hi, Dr. Sam. Hi, Dr. Francisco. Yeah, Dr. Shalini. Yes, role of probiotics, Shalini is asking. Yes, Shalini, we are using the probiotics. Of course, the probiotics are helpful for everything. These days, lot of studies are coming for the use of the probiotics. Yes, you can give the probiotics, no problem for that. I'm taking one lecture on the 24th for the role of microbiota in infertility, vaginal microbiota. If you are having time, do join on that on the 24th. So yeah, lot of friends have joined from other countries too. Hi, Dr. Francisco, Dr. Hassan, hello. Hi, Dr. Neelam. Especially in the menopausal females, we are giving lot of patients, we are giving the probiotics. Yeah, Anurita, acha, okay, Anurita, you can please unmute and tell us about all. Anurita, you can unmute yourself and tell us about this preparation, what you are
Yeah,
writing.
ma'am. Good evening,
Yeah.
Ritu. Wish you a very happy
Good
new year
evening.
and all the
Thank you,
panel
darling.
consultants.
Thank you, dear.
Ma'am, actually, we nowadays, because of the increasing all this hectic lifestyle and all girls and even married ladies getting involved into night shifts and other thing, very often we come across. But what topic you have taken, it was a very hot topic, because during pregnancy we really are confused. Being an Ayurvedic infertility specialist, usually when we conceive, we get the cases with conception, and after this we get this pyelonephritis or some conditions. The Chandraprabha Google and Gokrugan. Gokru is a Gokshu, that is Terminalia shibula and Terminalia shibula. These two contain Gokshur, which is called. If we have a Ghana, this thing, it doesn't have any other metallic preparations, plain vanaspati. It gives very good results into any type of UTI, even pregnancy, very safe, having no side effect. And if there is like you want to use it at antibiotic higher level, you can give a combination along with Chandraprabha Google, because Chandraprabha Google, when you give 1 TDS on BD or even 2 BD Gokrugan, plainly it helps a lot. Along with that, like usually when we say okay, pregnancy, the condition is like that, many a time that is you need to handle the mentality also. So very simple thing which is available at our home, that is ajwain and dhania, and along with that mishrex means jo apni mishri rehti hai. If you just soak it in the water at night and morning, if you just say them, we get the results even onto nausea, UTI, and mild feverish feeling is there into pregnancy, that they don't feel like to eat anything. It is just mild feverish. Even that it is helpful. So just like an drink, we suggest anytime. You can suggest with this along Chandraprabha, Kokru, and you said very well, probiotic, because I use very organic nutritions also. Along with probiotic, whenever pregnancy is there, the vitamin C intake should be very good. It should be very, very. I usually suggest amla or amla churn or amla candies. But if usually we avoid the sugar, this thing. So I have a very good antioxidant combination called C plus, which is a Forever Living company. We imported. It's a very fantastic 1 TDS or 1 BD or 2 BID, because those a lot of acidic tendencies there, nauseating is there. And along with that, UTI is there. So once you reduce the acidity level and infection both, pregnancy is very happy and very important, because you very well know infertility के बाद में patient के babies बहुत it's very a big headache to us, because they're very precious to us. So just
Anu, here I want to just ask you, as you
Yeah.
told about this mishri and this ajwain, we better will use the English term, because so many other countries
yeah
from
yeah
the
yeah
doctors. So now,
Yeah.
so once we say this ajwain is what? This
It's
caram, na? Caram,
asafoetida. I think it's
asafoetida, no, asafoetida is hing.
yeah,
Ajwain
sorry,
is caram, I think, caram.
it's not
So,
carom, ma'am.
Asafoetida.
One is
I think,
coriander seeds, that's
no,
dhania.
coriander is dhania. Coriander is
Yeah.
dhania. Ajwain is
And
carom only. Carom only. CAROM. I think carom only. Huh? So
give me
no, I
one
just want to ask, because as you told that this mishri and because some patients have a tendency ki if we take this ajwain carom seeds, that they are having more heat. Huh? Carom only. Huh?
No, ma'am, we reduce. That's the reason I said the process, that it should be 1 glass lukewarm water, and
Okay.
with that, half a tablespoon of coriander seed powder, and
Okay.
1/4 tablespoon of ajwain. I'll just give you the name of it, because it's just on the tip. But I thought, like, regularly after a long time, I saw your this thing, and I was just after my hospital free at home.
Okay.
So I
Okay.
joined. I was not knowing it.
No, that's
So
good.
if you soak,
And what about the use of this mishri khadi sakhar? So, but how
yeah.
can we give in the patients, because some of the patients we are having this gestational diabetes and UTI. So again, if we are giving this khadi sakhar, it will again disrupting their sugar levels. Huh.
Yeah, ma'am. Actually, when usually if you have a
Good,
diabetic
you have on
patient,
the
I
camera. Too good
yeah,
to see
ma'am,
you.
because
All of the friends,
uh,
those who can on the camera, please on the camera. Long time we have not met. Yes, I am planning to start some 2 or 3 physical CMAs, so we will meet soon. Yeah.
okay.
Yeah.
Actually, when a patient is there and it is diabetic, you should never give any sugar. It should be processed, or it is brown sugar. I never suggest it, but I use lemon honey into these conditions, and into that you can just without sugar you can give the things to the patient,
Okay.
because it's very mild. Usually after soaking into all lukewarm water 1 glass, hardly we get some essential oils into it. But when you give it in the morning, it gives you very good appetizing tendency. Also appetizer is as an appetizing also, it's very good. It's very good for cleansing of kidneys and filtration rate. And secondly, usually in pregnancy there is very mild UTI. Usually she's in suffering of this. It's very good and very mild also. So in first trimester I usually give it, and in second trimester I use more with the aloe vera and other things which are very good
Okay.
for.
Okay.
Nice
Okay.
to see you after a long time. Yeah.
Yeah, same here. Hi, too good to see Shalini. Too good to see you, darling. So I think we will wind up then today. So I have, yeah, hi, Dr. Helena. Too good to see you here. Dr. Srigura Helena. Dr. Arvind Tiwari. So many friends are joining. Yeah. So we will wind up for today.
Yes, ma'am.
Yeah. Okay. Thank you, dear Sahiti. Thank you, Shield Connect. Friends, please stay tuned with me. I am coming with the one more new exciting academic series. So do not miss my post. जो मिस करेगा वो एक बहुत अच्छे सेशन को मिस कर जाएगा. So stay tuned. I
Thank
will
you.
come.
Thank you.
Yeah, most
Namaste.
welcome.
Namaste.
Yeah, bye bye. Bye bye.